Welcome, everyone, to the Cultivating Compassion Education series provided by Compassionate Care ALS. We're honored tonight to have our own medical director, Dr. Suzana Makowski, here to give her talk about how to find your voice and advocate for yourself. Very interesting topic. Thank you, Suzana. Just a few words about Dr. Makowski. She's been on our staff now since the first of the year. She holds a volunteer associate professorship at UMass Chan School of Medicine, teaching and mentoring students. She teaches healthcare, communication, and palliative care nationally and internationally. Suzana received her AB from Bowdoin College, her MD at University of Rochester School of Medicine and Dentistry, Master's in Medical Management from Marshall School of Business, internal medicine training at Bay State Medical Center, fellowship in integrative medicine at University of Michigan, and fellowship in hospice and palliative care at San Diego Hospice and Palliative Care. She is a board certified hospice and palliative care certified physician executive. So much more we could say about her, but very happy to have you with us tonight and on our staff with us, Suzana, and I'll turn it over now to our founder, Ron Hoffman. Welcome, Ron.
Hey, thanks, James. Welcome, everybody. It's good to have you all with us. It's really good to have Suzana on our team. Suzana and I go back 16, 17 years, I believe. And you have a palliative care doctor on board that speaks a very similar language to me is really, and it always has been important. So she's an incredible asset to the extraordinary staff that we already have. Yeah, one of the things that has always been incredibly important to myself is the art of language. You know, being able to speak with people, to be able to hear people in a very, in a way that honors them where they are. To be able to hold that space and be able to listen. You know, oftentimes folks don't even know the questions to ask. So to be able to show up for people in these extraordinary circumstances and to be able to truly listen and to be present with a very, very open heart is so incredibly important. And you know, Suzana brings that skill set to our team, and the knowledge that she brings in all of her years in the world of medicine at the bedside of individuals navigating their different circumstances. So I'm grateful Suzana's here, and you know, I'm sure we'll all garner some really good information from her. So I'll turn it over to Suzana.
Well, thank you. Thank you, Ron and James. I want to, just echo what Ron said. We met a number of years ago, a couple decades ago, actually, when we shared some patients, and our kinship and parallel ways of being present with was something that struck me from the very beginning. As mentioned, I'm an internist. I grew up internationally. I was born in Brazil, and I lived in England and the Philippines, Peru, and I came to the States to live first as a boarding student in high school when my parents moved again to the Middle East. So I had a chance to talk to them in a little cubby phone once a week for 10 minutes while I was learning the new culture of being a teenager in the United States in New England. And what I think that international background, one of the things that it gave me was a way of listening to people with their voice rather than imposing mine and assuming everyone would understand me. It would be a way of being present with what came up for me. And this has really served me well in my work as a physician. And then when I was lucky to go to University of Rochester that taught us an approach to interviewing people where we got to, in our first 2 years, listen to people share with us their experience of living with an illness while we were studying that illness in the textbooks. So we weren't learning how to interview them the official physician way. Instead, we were learning how to listen and learn from people living with illness. And it was only much later that I realized how unique that experience was and how much it influenced the way that I learned and integrated talking to people living with illness, talk to my patients, where I would elicit their narrative and let them tell their story. And then I would translate it into the way that we document or the way that we communicate with one another. And that doesn't happen for many physicians. And I'm giving you this backstory to share a little bit of some of the themes that are going to come up today. I'm going to share a little bit about how physicians are taught to think, because I think some of what we talk about today is how do we effectively advocate for ourselves or for our family members when we're in the doctor's offices. And the other part of that story, which this approach, both growing up abroad, studying non-science as an undergrad, and learning about this biopsychosocial experience of illness. The illness doesn't just affect a body part, it affects a human being's life, and their relationships and their hopes for future. What that does is my approach of how I interact with people and what I think we do in CCALS and many physicians do, whether or not they know it, is if you think of a 3-act play, a movie that you've recently seen, or the hero's journey, where life starts off the way we know it, right? Life, the first act is life as we know it. They establish the scene. And then act 2 comes around and life is turned upside down. There's been an event that has changed life and has called the hero to action. And the hero at first is a little bit reluctant. I want to keep things the way they are. I'm going to stay the way they are. And then there is an ordeal, and perhaps a really supreme ordeal in the language of the stories of the hero archetype. And that supreme ordeal challenges us in all our sense of being and often takes us to the point of death. And that's when the hero might encounter a person or chooses a different way to interact with that ordeal and unfold what comes next. And it's that point that we usually end up meeting people living with ALS. You have gone through, many of you have gone through, have experienced that supreme ordeal. And I see that part of our role is to help ease the ordeal through all the technology and the things that we share, even when we can't fix it. But also the other thing that we are here to do, and that has been a privilege in my work in palliative care, and I'm hoping also to bring this forward is in this talk tonight, is to help the protagonist in this story, the hero in this story, to be able to write that 3rd act, to be consistent with the way that they want their story to unfold and be told. So coming back to personhood, another physician, Eric Cassell, has talked about suffering as being anything that infringes on personhood. It's different from pain. Think about childhood. Childbirth can cause a lot of pain. They say that's one of the worst pains that someone can experience. But there's not suffering usually. If it all goes well, you're not suffering through that. There's pain without suffering. But ALS takes away so many aspects of personhood, our sense of role, our sense of purpose often, our sense of future, our dreams, our integrity, our independence, the hobbies we like to do, and all these things that contribute to personhood can be taken away by this illness. And then you add on the burden of healthcare and the way that most physicians are taught to talk to us, where all of a sudden the shift of the role and the voice of the person, the protagonist no longer is the human being that we're talking about, but it becomes the illness. even in our lives, and even when I go visit people in their homes with their families, sometimes our focus so much is on what equipment do you need? What is your last loss? What can and can't you do? And what is left in the corner on the side is the human being with hopes and dreams and a history and a sense of purpose and love and loss and heart. And so part of today is how do we re-find and redevelop the ability for that part of ourselves to be present in our interaction, our communication, and even the decisions that are made in healthcare. So with that, I'm going to screen share. And please, if anybody has pressing questions to ask here too, don't hesitate to put them up in the chat section, and I'll do my best to address them. All right. So this screenshot didn't come out as well as it did, but this is one of the images from A Hero with 1,000 Faces. And so I wanted to start by actually talking about one of my hero I recently met, who actually is having his memorial today. He was a runner. He ran the Falmouth Road Race every year, a father and grandfather, a teacher, a neuroscientist, a mentor, an author, a lecturer, a friend. He was known to be thoughtful, kind, generous, and always producing a next innovation in how to make lives better for academics and neuroscience. His research focused on exercise for people with Parkinson's, and because there wasn't much drug money involved in it, that research dried up, and he shifted a lot of his focus on how to survival skills for neuroscientists, and mentored many, many people, including some young people in his lab, one who has almost been adopted as part of family. Then he developed neuropathy, numbness in his feet. Running became harder. No one knew where it came from, and he continued. He continued to run, he continued to mentor, continued to teach and lecture, travel internationally, write books, publish. They developed back pain and itching and weakness in his legs. He went to neurosurgeon, there was no spinal stenosis. He continued to write and speak and travel and publish. And then he started to fall. And then his neurologist did an EMG and the ALS diagnosis came. And all of a sudden, he couldn't run. And he no longer was a neuroscientist, he was a neuropatient of ALS. His life was really turned upside down. And yet he continued to write and to publish and to mentor and lecture. In fact, he gave me one of his publications just last week that just was published. And then he was hospitalized after a tough week or two. He started to lose his voice. He couldn't teach, and he couldn't travel. And his conversations with his neurologist, great team, thoughtful and kind, were around the treatment options that he had. And yet he somehow asked the question, is this working? And is it giving me what I want? And it was right around this time that Ron asked me to go and meet him and his family, right after this really tough hospitalization where his voice got weak and he was no longer able to get out of bed. And he talked about how he no longer was the person that he was, and his life was focusing on his disease rather than all of who he thought he was. And because of this, he said, it's not the way this is not the life I want to extend. If this is as good as it gets, I want to focus on what was. I want to focus on my legacy. I want to be with family. I want to see the ocean and look at the pictures of my family and tell stories and reflect, but not prolong this time indefinitely. And the questions that arose when I was there and meeting him and his wife and his dear friend, and the kindness and openness that he allowed and invited in that space was truly something to witness. And that's one reason why I say for me, this was for me a heroic moment. His wife asked pointed questions about, well, what if we got you up in the chair and rolled you out to the deck outside so you could see this amazing view every day? Would that not give you more joy? I asked, what if I could help your doctors better manage your pain and your symptoms? Would that improve your quality of life so that perhaps you could have more joy or more sense of purpose or see something different? His friend said, and we could write another paper. Would that give you enough joy? And he said, I'm tired and I've had a good life and this is too hard. And with that, they respected him. And they talked about how to talk to his children. As physicians, neurologists, and oncologists and others, when they partner with patients, there becomes a kinship. And they're always, good neurologists, good oncologists, good doctors are looking under a rock for what else can I provide to help you live longer and live better? Is there something else I can do? And sometimes not being able to look or not looking creates an incredible sense of failure. And similarly, once that relationship gets close between doctor and patient, sometimes it's hard for the patient to say no thank you to their doctor for fear of hurting that relationship. But he had the courage to say, this is important. I have lived a full and good life. And now it's time to focus on something else. What happened next was he ended up signing on for hospice. His symptoms were managed as well as could be, but he quickly let go. After his son's visit, who has also published books, and after he had a chance to reflect and talk to his family. And yet the legacy that he had and the focus in the last few weeks was around what he accomplished in his life and what he's leaving behind rather than what he could no longer do. And so that hero's journey came back to a reflection and a celebration of his living, rather than a grabbing onto something that was failing him and stealing him of what were his values. So he had a chance of being heard and to be seen and to be noticed, and that his story was more than ALS, and how much the options for care and how we could care for him, how people could care for him, could affect that personhood, not his illness, although that was a major part of it, but it was around who he is and who he was and how he wanted to be remembered and how he wanted this chapter to unfold. So being heard is so close to being loved that for the average person, they are almost indistinguishable. Now, this gentleman, I could still hear with a voice amplifier. And his speech hadn't slowed down that much. with ALS, what strikes me is how all these things get harder. Everything gets harder with ALS, and speech gets harder. So how do you make sure voice is heard when these barriers kick in? And I have to tell you, as a physician who's seen this, who's practiced for a few decades now, even people who can speak loudly, once they're lying in a hospital bed or sitting in a gurney, looking more vulnerable, voices tend to shift. How well people are heard. People are seen as patients rather than people. And when sense of humanness can be lost in medical care, and that can add to suffering. So that's why I find this is so key. And the thing that I want to share with you today is I am not going to focus so much on the tools, and I'm not going to focus at all on the tools and techniques that Christine is so good at addressing and others are so good at doing to overcome speech challenges. Because she would even share that even with all the tools and techniques, people interrupt, they guess words before they're finished, sentences don't get to be told, and one story is often lost to the disease. So instead, we're focusing on these other aspects. So indeed, the practical is important in order to get our needs met, in order to be able to find some way to communicate, to address the things that worry us. And those practical ways of communicating, whether it's high tech or low tech, will help get our thoughts and feelings and concerns across. And I think the other thing I want to share is, it's interesting. I remember early on in this time working, in the last few months working with Ron, I mentioned something that I'd heard years ago, not related to voice banking, called a voice library. And it's very different from voice banking. And you will see in a little bit when I tell you about this. It's more around recording stories rather than recording words or phrases to be used. So there are these aspects of how do we make sure, how do we plan ahead in order to make sure our personhood is honored, not only today and not only in our needs in this moment, but as our disease progresses, and even how can we influence how we will be remembered, and how rich this time together, this time that we have coming up, is left with. All those things can be influenced. And that in turn will affect what we call, in terms of suffering being anything that impinges on personhood. If we can find ways to enrich or continue to feed the roles in our current relationships, not only as spouse, now perhaps as receiver of care from our spouse, but how do we foster that relationship as spouse or as parent or as brother or as friend or someone who loves music, perhaps once playing it, maybe we can't play it anymore, but what can we do to engage those things, hold on to the things that matter most, that fed us when we felt most alive? So first, I will go and talk to some of the practicalities of talking to doctors and other clinicians. The research shows, and this is for everybody, even people who can speak really fast, that physicians on average interrupt patients within either 7, 11, or 18 seconds, depending on the specialty and the day. And so within someone speaking for a few seconds, a physician generally interrupts. Now, sometimes it's thoughtful interruption, but how much information can you really get across in 7 seconds? And what they found out was that some people who weren't interrupted had figured out how to get their thoughts across in about 7 seconds, so they didn't need to be interrupted, I guess. But they were very efficient speakers, I guess. And there are a lot of different reasons why I think physicians, despite our being taught to ask open-ended questions and wait for the answer, why we tend to interrupt patients. And Unfortunately, with documentation these days and increased time constraints, all these things are, and our concern about who is next in the waiting room, et cetera, et cetera, et cetera, all these things feeding into interruption. So how can you, especially as your voice gets slower or your speech gets slower, whether you're speaking or using augmented technology, get your communication across effectively in a way that you'll be heard? The next part of this is, how do doctors document? How most physicians are taught to ask questions is to ask questions for our documentation, not to elicit the narrative, which was the school that I went to. So this is kind of, when we do a full history, these are the components of what we document. We write down what's the chief complaint or chief concern, then the history of present illness or the interim history, a review of systems, a social history, past medical history, exam, and then assessment plan. And this first part is the place where you can have some control over this. And if you have some of the things pre-written out, it might make your time with some of the physicians more efficient. In particular, the chief concerns or complaints and some of the key things that have happened in the interim history and key aspects of your social history. So for example, if there's a big family event coming up that you want to figure out how to get to, and is it going to be possible, and what will I need to have in place from PT or OT or speech in order to help make that possible, or to be able to plan. Or my daughter is getting married and she wants to ask me how long, when the date of the wedding should be. All these things can help the physician be more efficient and focused on focusing the discussion around your needs, if you know what those are. Now, there are going to be some things that they're going to go over anyway. And if you have somebody taking notes with you and getting a sense of the rhythm of what's coming up, by having some of those pieces written down ahead of time might help you spend more time on the things that matter most to you. Does that help a little bit? The other thing to consider when thinking about those, so the chief concern or chief complaint, the thing that I would share in there too, is what are some of the things that are coming? What are you worried about? What have you noticed has changed that you really want to make sure the doctor knows? What are some symptoms that are coming up for you that are really some of their symptoms because they assume the neurologist knows about them, or they don't want to burden them with these symptoms, or they've heard that, for example, pain isn't supposed to exist with ALS, but I'm in pain, so am I just complaining? Should I talk to my primary care doctor about it instead? No, talk to your neurologist who you're seeing about those things that are really interfering with your quality of life. Make sure that they're known. Don't assume those things. And the other thing around social history is if there's some major family changes that are going on, the physician might be able to be an advocate for you on some of those aspects. Or if there are some major issues coming up, they might be able to address and schedule appointments to make it possible to not interfere with these major events in your life. So focusing and being able to craft some of that interview around the things that matter to you as a human being. Now, the one thing that is not in here that I really love and is did some research on dignity in healthcare. And I asked him, why in the world are you studying if dignity matters in healthcare? And he said, well, you know how it is. A lot of scientists and doctors don't think it matters unless there's data to prove it. So he proved that people like to be treated with dignity. And he actually developed some questions that can help physicians and other healthcare providers to tend to people with dignity. And one of the questions I really love, and I encourage people to write out or share as part of the chief complaint or part of the document that you would share with your doctors, is this, the answer to this question. If I was your physician, I would ask, what do I need to know about you as a person in order to, that might affect your care, or in order for me to give you the best care possible? So I would reverse that and say, there's something that I want you to know about me that I think is important in how you care for me. And it might be anything from something about your family to something about your faith to I'm a pragmatist. Whatever it happens to be. Like there were some examples that some people shared. A woman with breast cancer went into a hospital, and the medical students asked this question. And she was somebody who really always, she put her makeup on every single day and really was distressed when she didn't look a certain way. So she put that up there. And so the aides went in and helped her with that every day of chemo and even after her surgery, which helped her recovery and her sense of well-being. So even details like that can make a difference. Now, some other things, as Ron said, one of the pieces of communication is around meeting each person where they are and recognizing that no two people like to know the same amount of information, and no two people plan in the same way. So there are a few general questions that I think are important for you to consider when planning to meet with a physician. One is, how much do you want to know? How much do you think you should know, or someone in your family know? So if you're somebody who says, I don't want to hear anything at all, I'm not a planner, I like to live for today. ALS is one of those illnesses. It's helpful to have somebody in the family plan. So if it's not you, who? Just something to think about. Who else would you want to know? And then what is treatment? And how it might affect the things that are important to me? In addition, just to knowing that this is a good treatment for ALS, tell me how effective it is for me and my condition. And what are the worries that I should have in terms of these? I just told you a little bit about who I am. How might it affect those things that are important to me? And then I already mentioned that telling your doctors your symptoms are really important, because untreated symptoms can drain you physically and emotionally. And what we know is, it's exhausting having ALS. So to be further drained physically or emotionally is not a small thing, and it can affect not only quality of life, but time. There are two physicians out of Harvard, Groupman and Hartspan. They're a married couple. One of them is a medical minimalist. One of them is a medical maximalist. I'll tell you a little bit about what each of those things are, but this is also important in terms of communicating how you want care to unfold around who you are as a person, how you approach life, and sharing that with your physician, as well as maybe who you choose to be your decision maker down the road. So the middle one, the minimalist or maximalist, is, are you a medical minimalist or a medical maximalist? Do you believe that the most care, the most preemptive, have you been somebody who's really been on top of every single vaccine schedule, always taking your medicines on time, always jump to the most advanced medical treatment and medical care possible? Or are you somebody who's been kind of on the realm of less is best? I'll do preventive care, but I try and avoid taking antibiotics unless I really need them. And knowing that range of where you are can really help some of the decisions that come up around feeding tubes or all sorts of different things going forward in terms of just decisions coming up. So that's especially earlier on. And this might also help with some of the conceptual ideas of what happens when disease progresses, is thinking about, do I feel more comfort with more treatment, more technology? Or am I somebody, as my disease progresses, that would prefer lesser intervention, less technology? And this is a framework that can really help some people. And so this, I also wanted just to share, I'm going to share these slides with you. So this particular slide you could fill out or use, it's a type in here what my chief concerns are today, how am I feeling today, my biggest changes since the last visit, what I'm worried about. And then you can cross off any questions you don't want answered on this sheet, but I wanted just to offer that to you. And I also just wanted to treatment options and having conversations with your family about the difficult conversations about end of life choices and advanced care planning and what's next. And do I get a feeding tube? Do I not? Do I want to have a tracheostomy? Do I not want a tracheostomy? And these websites are very helpful around this. I'm hoping this will work if I click this. Can you see the screen? Honoring choices? Okay, let me do a new share.
It's pretty fuzzy, Suzana.
Can you see this now?
That looks good.
Okay. So this Honoring Choices Massachusetts in here is for Massachusetts. There are some things that apply to other states, but the forms don't so much apply. The legal forms, that is. The thing that I wanted to share in here is at the very bottom is it works through how do you think through choices, my personal directive. I do like, Ron uses 5 wishes, and I think that that is extremely helpful and can inform a lot of these. This is also very helpful. But what I wanted to focus on here was the 5 things to talk to your healthcare providers about. So this piece here at the very bottom of the document is really helping to form some of the conversations around what matter, how you can influence what the doctors tell you. Because in my interaction with a lot of the people I've met through Compassionate Care ALS, I've been surprised at how little some of the people I've met know about their ALS and what they're experiencing and why they're experiencing it. So even this first question, I'd like to understand more about my health condition, about ALS and its treatments. This is what I know. And what can you tell me? What am I missing from that? Or can you clarify some of these things? What information would be helpful for me to plan for the future? And you can say, I don't want to know prognosis yet. You don't have to know that. But what are the things that I need to plan ahead? Or what can I anticipate? And so by asking them to explain some of that might help clarify some of those pieces in here. Now, the next step on here, Ron and I have talked about this, and goals is a funny word, right? Because our goal, our hope would be to be free of ALS. Now, hope, I like the word hope in some ways as being something different because hope shifts over life, right? We might, so hope can be, I'm hoping to spend more time with family. I'm hoping not to return to the hospital, but that's very clinical. I'm hoping to, and might be, enjoy some family traditions together. So thinking about those aspects of what I want, what matters most, I'm hoping at the end of my life to spend time at home, to be at home with the people who love me, surrounded by X, Y, or, my spouse, my child, whoever it is, but not be bothered by these other people. So having those things really clarified can be very useful. So I just find this document can be quite helpful in terms of communicating with physicians. I'm going to go back to. So as mentioned, we start to move into this really difficult part of the conversation. A lot of you guys have already, the people who are anticipating losing your voice, a lot of you have been referred to people who can help you with voice banking. A lot of you have also talked perhaps to your lawyers about getting a will and estate planning. But I'm curious, and I'm curious also to the people of CCALS, how many of you have a healthcare proxy or agent form completed? How many have considered their advanced directives? And there was this this aspect of we will all die one day. Every single one of us will. And so by having those things in place, since we don't know when it's going to happen, is really important. And one of the analogies that I like to share with people is, most of us live in New England. We don't buy snow shovels, and we don't want to buy snow shovels in the middle of the snowstorm, right? Most of us want to buy them in spring when they're on sale. And buying the snow shovel in spring when it's on sale doesn't affect our wish for a snowstorm to come, or it doesn't affect when that snowstorm will arrive, but it will help us be prepared for that day. So having that conversation around advanced directives and what our wishes will be in the future and who we should have that conversation with is really helpful. And I'm going to give an example, actually using the 5 wishes, Ron's favorite document that aids filling out the formal forms. Years ago, I was working with a hospice nurse, and she had her whole family fill out the 5 wishes on Black Friday. So everyone's together on Black Friday, right? Families together. Everyone's had a lot of turkey and they're kind of chill. Football's done. There's not much to do. So this family said, well, I'll fill out 5 wishes and then talk it through. So they all did. And they gathered around at dinner and read aloud their 5 wishes, including the 8-year-old daughter and the 12-year-old son. And then after the nurse, this friend of mine, read hers, her husband looked at her and said, I can't be your healthcare proxy. I can't be your healthcare proxy now that I've heard what your wishes are, because it will be too hard for me to let you go. I love you too much. I can only be your husband. You need to pick someone else to be your healthcare proxy. And she thanked him. She said, being my husband is the most important role that you can have for me. So I will share this document with friends, and I'll find someone who can be my healthcare proxy. I'll make sure they inform you as to what's going on. And you will be on the form saying, please inform my spouse, but he's not my healthcare proxy. So picking someone isn't enough. It's having that conversation using 5 wishes, or having some discussion about where you envision those final days or weeks or months of life to be. And why is this important with voice? I think it's one of, I'm biased. I'm a palliative care doctor, so this is a conversation I have. But coming back to that hero's story, life as we know it, life turned upside down, and then there's this crisis moment, and how that 3rd act unfolds, and how that ending is in the movie affect the whole story. And each one of us, each one of you, deserve to be able to have some agency, to have some control, to have your voice known as to how and where, and if possible, that can be. And the one way to do it is to have that communicated. There's so many ways. One other story I'll share with you is, I'll never forget meeting someone in a hospital, and I was about to have the conversation with this patient. Comes holding this piece of paper that she's shaking in her hand, And she says, my mother told me to get this out of this little tiny scrap paper. It was on a little old napkin, all wrinkled up. She said she kept this at the bedside, and that when the doctor asked her to have this conversation, that I should get it from her drawer. And she said, if you're looking at this, don't you dare, or I'll haunt you for the rest of your life. So there are different ways that people can communicate their wishes to around end of life. And people know, hopefully you'll know what that means. But talking about the elephant, facing the elephant, buying that snow shovel early will actually be perhaps one of the most amazing honoring gifts to your own life and to that healthcare proxy, to the person that you choose, that you trust to be your agent. It'll also be a gift to them because it alleviates their sense of burden to make those choices on your behalf. They will be doing it knowing that this is what they wanted, and they don't have to be the one that makes those hard decisions because these decisions are hard. Martin Nepo's a writer, and he actually survived a pretty tough bout of but it taught him that he had to start learning how to live 1,000 years in each moment. Decisions, these decisions and the thoughts that you have, I think the key thing is to have it stemmed again from your story and your legacy, your sense of values, what matters most to you. And linked to that is also moving away from the medical conversation is to make sure and invite space when you have the energy, when you have the voice, when you have the ability to also give space to talk about what matters most. And there are a few different frameworks that I have learned in terms of these conversations. One is Ira Byock has written a book, The 4 Things That Matter Most, to say to someone who's living with a serious illness. One is I love you, and I love you for. What do I love you? Why do I love you? Please forgive me. We all have regrets. And so to be able to share them once again, I forgive you. And my favorite perhaps is thank you. Thank you for. Thank you for. And the thank you can lead to conversations about memories and passages of time, things that you've shared together. And it's an incredible way of eliciting stories that bring tears and laughter and joy and really help us integrate that sense of personhood, that sense of life story, that sense of the things that we've shared together with meaning and purpose. And it gives a sweetness to the bitterness of the illness that the ALS brings to people and their families. And then Max Harvey Chochinov's work on dignity therapy, he has some wonderful questions too on his website. And these images here all have links to, all are links to where you can find these. So dignity and care is the dignity therapy work. And some of the questions that he asks are, when did you feel most alive? And what helped you feel most alive? And of being alive, that one person said that ALS has taught me how to move away from being a human doing to really being a human being. And it's clarified And these are things that I'll remember from some of these people. So it's really incredible what some of these questions can ask. Asking, even stories of people, sharing stories to record every now and then that you can hand on to grandkids and that we can hear them in your voice. So this is one of the things, this voice library, I met the gentleman who founded the voice library. He lives up in Exeter, New Hampshire, or Seacoast, New Hampshire, around there. And he, basically the voice library is a website that is not shared. There's no advertising. It's not social media. People have a chance to record stories and share them with whoever you want those stories shared with. So people who go off on with the military, their families will share the stories so that when they were going to Afghanistan, for example, they could tune into the voice library in downtime and hear their family's voice. People with ALS, while they still have voice, are collecting stories in the voice library so that then family can hear them, so that their grandchildren or children can hear them read a bedside story in their own voice before it gets too fatiguing. And you can do that now with iPhone or other technology. This site will hold this library in propriety. And you or your designee can always have access to it. Music and memory. Some people have recognized that people with dementia music can tap into memories in a way that even as we lose other memories, we hold on to. But what that has led to is some medical students started using a way, instead of doing a dignity interview as to what made you most proud, what are some memories that you've had that you'd like to share, what are some things you want to share with your family, they started interviewing patients about their favorite songs and music pieces and created song lists with music that then could either be shared with family or that the people could listen to. So tapping into, and remember when we used to make those old cassette tapes that we would give to our boyfriends or girlfriends? We can do that again now and have song lists with our favorite songs and music, and even songs and music that bring back memory and voice and elicit story. And then this other site that I have here is What Matters Now, which was developed by a woman who was a hospice volunteer as a teenager and then she started designing websites. And it's a nonprofit website that is free for anyone who uses it. And it's geared towards people living with serious illness and their caregivers. So that it's a way of simplifying communication with all the people who are asking 1,000 questions. You can post updates periodically when you want to. You can post, I need this help, or visiting hours, when's most appropriate. And people can also go in and share stories and share memories and send photos in there of things that matter most about that person. And I would include in there those aspects of not just the practical care needs, but the why behind what matters most in your life, what matters most about this life, what matters most about your life, what matters most to you. So that is my talk. And I want to just share one last thing. Is one of the things that is one of my greatest honors, in my whole career in palliative care, but perhaps it's really come to fruition in my work with CCALS, thanks to Ron and thanks to the people who fund this incredible organization, is I see part of my role of helping to be kind of the editor in the background to help people craft how they want their third act to look. And then I tap into the team at CCALS and I can reach out to physicians or agencies to see how and if will that be possible. So I'm here as a resource also to help think through some of those difficult conversations with the people that matter most, to hold space for them. And I know most of the people on the team here are too, but I'm available as well, right, Ron? And it's an honor to be here. And thank you to all my heroes and all of you who I hope to meet, who will continue to teach me about courage and about resiliency and about how to find your way home. Thank you.
Anyone have a question? Just post it in the chat or raise your hand in the reactions and we can call on you. Suzana, do you want to read those chat questions, or looks like it's just a thank you, you're wonderful, thank you. So any questions for Dr. Makowski? I have a question, Suzana. When you're with a doctor and you feel like you're getting interrupted and you want to try to have a more personal relationship, how do you muster the sort of the courage or the forthrightness to just say, hey, I feel like you're not listening to me? Or, I mean, is there a tactful way to do this? Because I think often it's intimidating to speak up in front of a doctor and say, I'd like this to go differently than it is.
I think it depends on who's in the room, right? There are a couple of things that I would share. One is I would actually have a code word, because most of you are not going to see the doctor alone. Most of you will be there with a caregiver or family member or partner. Is that right? Would I say? And so I would almost have a code word to get that person to say, hey, could you have them redirect? Or one example, for example, that I wanted to share is very often when people become disabled or have difficulty with voice, physicians will end up starting to talk in third person in front of the patient to their family member, right? And so this is a time where the caregiver family member can say, could you please redirect the question? I might help them answer it, but please talk to my spouse or to my family member or my friend here, and you can help advocate for them that way. The other thing I would do is, so the reason why I like to put in that thing of what is important for you to know about me is, so for example, in my notes, I usually, before I came to CCALS, I would describe a little bit about who somebody was. So I'd say, Mary is such and such year old, grandmother of 15 who loves collecting bowling balls. And I knew someone who collected bowling balls. It explained a lot of her back pain, but there it was. And it was something that she just loved. Or, and so some of these things about having something about who that person is, and to simply remind the physician to say, I need you to know a little bit about me as a person, not just my disease, or I need to bring back this piece. And if they say, well, I don't have time right now, you can say this is important and perhaps why. I think there are ways of doing it. And I think also having some of those, with those slides, having some of that, especially because communication can be slow. If you have those chief concerns, those questions that you have, or even some of the interim history that you've noticed, some of the things that have come up for you, pre-written out in your own voice, in your own narrative, to hand to the physician and say, look at this before we start. That can help influence that conversation, and I would encourage you to do that.
Yeah, thank you, Suzana. A couple things. And as Suzana was just speaking, it came to me, another thing that we can often do is look at our physicians and let them know or say to them, I'd like to tell you who I am. I want you to know who I am as a person. And you can share what you choose to share. Suzana was speaking of, the different forms in Massachusetts. There's a MULST form and there's a this form and even the 5 wishes, which I'm a fan of because it's user friendly. It allows you to put color, to use color to express feelings. Some of the other forms are kind of black and white. But I think the challenge that we all have regarding forms, and of course, dealing with such a diagnosis, the challenge is, how do we become familiar with the reality of the circumstance that we find ourselves in? Likewise, how do our physicians themselves learn to become familiar with the reality of their own mortality, because they're sitting across from someone who's actually facing their own? In a perfect world, all our physicians would be Suzana, Dr. Makowski. But we don't live in a perfect world. And it's not that our physicians aren't good people with good hearts. It's just they haven't, or are unwilling, or just afraid, like many others, to become familiar with the reality of their own mortality, their own dying. And I come from a place, if our physicians that I have aren't willing to do that, then how are they best going to show up for me? So there's no judgments. That's just the reality that we live here. And it is getting a little better. Thank goodness. How do we, and lastly, how do we all just learn to lean into this a little bit more? Be willing to inquire within ourselves, ask ourselves those questions silently to ourselves, because maybe our spouses, our partners might have a hard time with that. So communication is so incredibly important. And for those of you that know us and have been with us for a while, we're those sounding boards. I'm grateful for Suzana. I was able to introduce her to this gentleman after I called her, after I visited him in the hospital. And, I wanted a really good clinician that has an extraordinary heart. There's great clinicians out there, but often what's missing is their heart and their ability to show up and listen. And that's what the piece that I'm so grateful for that Suzana brings to the table for our families. I'm not a clinician. I know what I know. I also know that I'm not able to converse with other physicians. Many of them aren't going to give me the time of day. I don't care how long I've been doing this. But palliative care doctor. So it helps on many, many, many levels. Again, for all of us, myself included, how do we all learn just to lean into a little bit more about those difficult choices that we're all confronted? And know that you're not alone in doing it. There's always an ear here with myself, Dr. Makowski, James, our team. So that's all I have, James. Suzana, thank you so much.
Thank you. I want to, Ron, if I may, one of the things that you brought up, I want to just clarify one piece about the documents. I didn't want to go into that too much today. There are a couple things that I think are important. In Massachusetts, having a healthcare proxy is really important, because if you don't have a healthcare proxy in Massachusetts, once you lose the ability to communicate, the courts will decide who that person is. So if you don't want the courts or your family to have to go to court, to probate court, to identify your decision maker, please fill out that healthcare proxy to determining who that spokesperson will be on your behalf. So that's one thing. The other is the most, and that's similar in other states, but not all states are quite that stringent. It's a little bit different in each state, but that Massachusetts tends to be very strict that way. The MULST form, if you know your wishes and you have some very clear decisions that are already made around, especially not wanting certain things done. Like if you do not want to be intubated or have a tracheostomy or get CPR, you need to have that MULST filled out, because without it filled out, if they find you in a situation where you're not breathing, the paramedics are almost obliged to do the CPR and do the intubation. So if you do know those wishes, that's one reason why sometimes physicians really push for those things. And Ron knows my approach is we offer these things, and there's some useful discussion tools and ways that we say maybe today you're here, but down the road your choices will be different. But I just want to just clarify that a healthcare proxy form or a legal form or 5 wishes won't prevent the paramedics from doing those things. So I just wanted to clarify some of that without focusing on it as well, because I wanted just to make sure that if you know, I want to make sure that you have what you need to honor those wishes.
And I'm just going to end this with this. There are so many situations and possibilities, thus conversations with your significant others and your families and conversations with yourself. It's important to find out, well, if I did this, what does this look like? In other words, there's many choices, there's many possibilities. Okay. So it's just self-inquiry. What does all this look like? It's about painting a picture that we wish oftentimes our physicians were capable of doing. All right. So there's many different scenarios, and it's just really good information that was shared here this evening. Anyway, James, anything else before we say goodnight?
I think that's it. I just want to make sure that everyone knows we will have this recording up on our website in the educational library here soon within the next few days, and you can go through that and look at any of the slides that Suzana presented today. If you would like a copy of the slides, let me know, James at CCALS, and I can be sure and get those to you. Is that okay, Suzana?
Absolutely. Yep.
So just write to me, James at ccals.org, and we'll get you that. And otherwise, you can check out the recording. So thank you, everyone.